getting started. We're getting started. Calling everyone to attention. I would like to take this opportunity to welcome everyone. My name is Dennis Onyango. I'm the Programs Director with Africa Advocacy Foundation. My work involves working with communities, migrant communities across Europe. And so it is a privilege to be able to have this summit, which is the first of its kind, at least as far as I know, that's bringing together various stakeholders to address issues of migrants. We, as a migrant community, obviously have a lot of challenges, a lot of barriers around access to healthcare, which are very well documented across Europe. And as you know, healthcare is a devolved function normally in many European member states. Each country decides who accesses and who does not access healthcare. So it's really, really a privilege to be able to do this summit. We have worked collaboratively with UNAIDS, Dr. Gary Jones, who is going to come here to give opening remarks. We've also worked closely with Ferenc Bazinski from AIDS Action Europe to put together this summit. And of course, we are grateful to Gilead Sciences that was sponsored the summit, and also to other funders like VIV and MSD who have supported our Mi-Health initiative, which involves a network of community organizations working with migrants across Europe, and also a capacity building initiative aimed at strengthening us as community advocates to do well in what we do. And so it's really important that we have these 2 days. The intention was to have the first day the intention is to have the first day focusing on community issues. So this is where we bring our experiences and our showcase our work across Europe. And then the second day is supposed to be a policy-focused day, where the discussions from the first day are explored in further detail to see how action can be taken to address some of the issues that migrants face across the cascade of care. And so today we will have a lecture that's focusing on issues of migrants, and then we are going to have various workshops going forward. And so it's a great privilege to, of course, welcome Gary Jones from UNAIDS to give opening remarks. Gary has worked in the public and private sectors with academia for over 40 years. He's involved with policy and programming in long-term and stable environment, as well as humanitarian emergencies, including conflict as post-conflict. Gary has experience in promoting protection and community well-being amongst migrant, transit and host populations in rural and urban settings. He has been a volunteer, a country director for an international NGO, a social responsibility manager for a multinational company, a program manager for United Nations, and is currently ending his term as a senior advisor to UNAIDS. Gary has authored work on HIV, decentralized systems of healthcare amongst indigenous minorities, migrant access to care, and support and health system strengthening. So Gary, you're most welcome to give opening remarks.
Thanks very much. Okay.
Just a minute. So I've just been reminded that I did not do housekeeping. So phones off, hashtag mind the gap, the toilets are out on your right. Gary, you're welcome.
Thank you for saying all that. I was going to be the first offender. All right. Okay. Good day, everyone. Lovely to see you all. I know some of you, most of you I don't, so I'm looking forward to getting to know you more. Thanks, Dennis. Thanks very much for getting all this together. We really appreciate. Right, I've got a few opening remarks. Please jump in anytime. We want to make this as interactive as possible. So please raise a hand, shout out, whatever suits, and then we'll get into that, okay? So we only have a few minutes. I won't be too long for you. I've got a few opening remarks. This summit, it's crucial as it's timely. Why? Because it's about rights. And as we know, with the exponential rise of migration around the world, now more than ever, we need to make sure that access becomes a reality. Now, these are plateaus, cliches, if you like, that we often hear, and it's the favorite discourse amongst many politicians. But we want to make it really a reality by grounding it. You good people here are the ones who are really going to help to facilitate this. We need to find those ways and those means where we can have effective collaboration. We can really identify those gaps, hence mind the gap. And then not just that, but come up with some real-time, grounded plans of action. At the UN, we all know too well what it's like to speak in the most lofty, the most wonderful terms, glowing terms about how we're going to end AIDS, I believe by 2030, so we better get a move on. But it's not going to happen if we don't get that real feel, that fire in the belly, that real commitment from you good folks. We see you as the frontline soldiers, truly, in this battle to end AIDS. So, the Global AIDS Strategy, or sometimes known as the GAS, but I prefer saying the Global AIDS Strategy, it really points out the need for a holistic approach for ending AIDS. It talks of the social determinants of health. Fortunately, I think for the better part, the world has moved on from it's not just about putting pills in mouth, that's how you end AIDS. It's a lot more. And I think the migrant story is of a special interest to us. I have experience, and I know people here will have far more experience than I, that you can organize the most wonderful distribution hub for ARTs, for example, for condoms, and that nobody really takes it up, even though people are very keen and they want to maintain the treatment. Why? Because they don't have the money on the transport to get to the hub, because they possibly prefer not to disclose an HIV positive status, and they don't want to be stigmatized. 101 different reasons may prevent simply keeping up with the treatment regimen. It's about shelter. It's about integration, about food and nutrition, about social protection. These are all the very key characteristics that make or break a successful campaign to end AIDS. These are the factors that we want to talk about. We want to hear from you how we're going to do it together, in unison. Migration has waves, and it takes place at different times in different parts of the world, fairly obvious. But what we have to realize as well, again, when we talk grand policy, grand global strategy, we tend to fall down on the one-size-fits-all approach, the cookie-cutter approach, if you like. But when we know that every migrant story is different, every asylum seeker has a different tale to tell. And unless we're going to be sensitive, unless we're going to find the means of how we're going to discover every individual experience, then we will not be able to plan properly a response. So yes, it is good that the media, the world media, picks up on the mass exodus out of Ukraine, out of Haiti, out of Venezuela, from the Sahel, and I could go on and on. But what it doesn't talk about too much is, and how then do we actually get down, down, down to make this a reality? I think for policy, we can open the door. We can create the correct legislation, legal frameworks which will allow us to work towards providing treatment, support for migrants, especially vulnerable or having HIV. But it's up to us to put the nuts and bolts on that legislation. Again, this is something that, as Dennis has often said, that we need to work towards. We need to grow our conceptualizing of migrant vulnerability, bring it down to earth, make it real. We need to change mindsets. Viruses transcend borders, a simple fact, but one which we often forget about. I think COVID-19 taught us that lesson, that if we have a migrant with an irregular status, undocumented, they should not be excluded from healthcare. A simple fact, but an absolutely resounding, pivotal fact when it comes to public health. Public health needs to be delinked from legal status in a country. It's that right to health. Nearly every country in the world has signed up to that. We have the conventions, the international instruments. Everyone has the right to the best possible attainable health in any situation. But how do we do that in effect? I often go back to a story when I was part of a focus group discussion, listening to some wonderful migrants. And they said, you know who controls the whole health agenda for migrants? And I said, who? And they said, the receptionist. And I said, what? And they said, basically, you can have the most marvelous policies, the greatest community activists, everything in place. When you go to the health center, an unfriendly receptionist, nothing happens. Absolutely nothing happens. You get a nice, and I'm sure most are very nice, doors open and you can access treatment. So for them, the way to end the epidemic is to train receptionists. So there's a bit of truth in that, in the sense it's that getting down to the last mile, so to speak. It's making sure that whoever we are, if we're the Prime Minister, the President, right down to the receptionist at the health center, we all know the story. We all know what has to happen. Now, there's a very strong cities component to the migrant tale. Again, not always. Sometimes a migrant, an economic migrant, will go to work on an agricultural farm. Look at the US. Look at parts of South Africa. But in many regards, and the evidence is showing, it's increasingly an urban phenomenon of heading towards the world cities, the huge growing conurbations. But we need to drill down. And within that, it's actually the city slums. It's actually those parts of the city which are the most resource constrained, which actually already have the worst health outcomes. And I often put myself in the position of a migrant. Okay, so maybe I have HIV. Maybe I'm gay. Maybe I now come to the city. Maybe now I don't particularly want people to know that I'm HIV positive because of the exclusion, the xenophobia that I may face. How am I going to then push ahead in a slum environment, already, no doubt, overcrowded, congested? Where am I going to keep my meds, for example? What's the storage like? I have to rely on private transportation to get me from wherever I'm staying across. Many of us were in Seville, in Spain, some weeks ago. And again, we heard time and again that even when you have the most fantastic HIV policies within a particular region, you don't actually have the money to get there, to get your meds. Moreover, when you fill out the form to get your social insurance, you have to put an address. Well, what happens if you're living under a bridge? What happens if you're just staying temporarily at a friend's place? What address do you use? Real practical experiences we need to shed light on, and that's what we want to do over these next couple of days. So yes, there is a strong urban component. yes, that is in the media's eye at the moment, and we need to know more how and in which ways we can use the so-called urban dividend to the best of our advantage. Not just the slums, but also migrant transit centres, formal and informal, are of a special concern to us all. The danger and the hardship, the trauma involved, for example, in crossing the Mediterranean, of crossing the English Channel. It leaves scars of my many migrant friends who have made that journey. You can tell, you look into their eyes, they are troubled. They've seen hell, they've been there and back. They feel the pain of what it means to leave everything behind to go to a strange alien environment. What are we going to do to be their best buddy? What are we going to do to support? We talked about social determinants of health. What of dealing with the mental effects? What of dealing with the psychosocial factors that are involved? Because, and I know very well that when I'm under stress, when I'm under pressure, I'll make the most ridiculous of decisions. It's human nature. You're off center. It's hard then to see the full picture. What of the experience of those migrants who've been to hell and back? Do you think everyone is going to be now of completely rational frame of mind? What are the support systems we're giving in order to ensure that we sustain treatment, whether that's PrEP, ART, whether that's post-exposure prophylaxis? Let's get into the mind. Let's get into the mindset. And again, reminding ourselves that every situation, every person is different. Spirals of poverty is my next note. Spirals of poverty that, again, not just economic migrants, migrants that have fled for their lives. Most recently, I was in Poland talking with a lot of Ukrainian refugees who'd come over. And some of them were quite well-to-do in many ways, but now they wondered what their future is. They did not have the skills to survive on the street. They just didn't know really quite what to do. It was a very perplexing situation. And now suddenly their mindset is, oh, before I had, and now I have nothing. I get some charity, I get some support, but now I don't. And you could replicate this experience. I've had this with Haitian migrants seeking solace, seeking succor in Central America, hoping one day to cross the border into the US. They don't know what their economic status is, and until, and if ever, it does improve, they're going to be amongst the poorest of the poor. Not poor in spirit, I hasten to add, but in pure monetary terms. So again, we know HIV, the many vulnerabilities, the triggers for infection. We know that simply, you live in a risky environment, you have to take risks to survive. If you don't take risks, you won't survive in a very risky environment, whether that's on a dinghy, crossing the Mediterranean, staying in a transit center, wherever it might be. You have to then take those risks, sometimes calculated risks, other times just wild guesses. What are we doing to try to prevent those downward spirals of sustaining poverty? How are we going to break it? Yes, we all know, and again, it's a bit of a cliche, how do we end AIDS? By ending inequalities. I listened to a documentary the other day where it's saying, no, we shouldn't say by ending inequalities. That will never go. We should talk about ending poverty, about making sure that each and every one of us enjoys the basic minimum standard of living. In other words, don't go for the real big shots of we're going to have fantastic development and freedom and life and blah, blah, blah. Let's just focus on making sure that each and every one of us can enjoy at least the very basics of a decent life. And I think that's, for me, is the roadmap for ending AIDS. We've got just a couple more minutes, if you will bear with me. We need to consider health referral systems. We need to consider how easy is it or not. A little bit of work I did with the Rohingya in Bangladesh. Again, doors open for many people living with HIV, particularly sex workers, to access treatment. But the referral system was against them. Many of the health professionals, sadly, were against them. What are we doing about trying to make sure that each of those links, as we join the dots of public health, each one is speaking to each other? Should we be doing more to provide safe environments which have an immediate impact on the status of personal and public health? How do we ensure quality-controlled health services, protection services? What about migrant housing? There's a good one. We can't live in a tent all our times. Look at the people in Syria. Look at the people in Lebanon, in Jordan. Recently I was in Jordan. And you see the tragic conditions that many of the people who lost everything from Syria are now living in. They have, living in a tent in the snow. Not a lot of fun. And of course they see what's happening in Ukraine and they say, that's great, everyone loves it, but why is that not happening to us here? The geopolitics, that's what we have to get into to try to make sure as we end inequality that we have that fairness approach, no matter where the geographical part of the world we're talking about. My last couple of points. Migrants have a right to work. A migrant generating a sustainable income will go far in reducing that risk that we spoke of. But how do we make it happen? Many migrants, they will invariably, so many, and I know there are exceptions, I'm generalizing, excuse me for that. They'll go to the city and they'll pick up any work that's offered, invariably from the informal, unregulated sector. Some of my own research in Kenya, for example, it's all about building, putting up the construction, and then so you just simply, wherever the next new building is, that's where you go. These were mainly migrants from South Sudan as well as from Somalia. But you go wherever you can, and then you put it up. There's no such thing as a contract. You're just simply paid at the end of the day. There's no such thing as a hard hat, and there's certainly no such thing as social insurance. So how, again, do we make that a reality? We need to do all we can to reduce those triggers, those various thresholds of vulnerability, to make sure that migrant populations, and I know that's a huge term, that's a huge compound term, but those most vulnerable migrants, displaced people, asylum seekers, who enjoy no rights whatsoever, remember, until you are a fully registered refugee. What can we do to get them into the workforce for their own sense of well-being? The feeling that they are not a charity case, depending on the next handout. When we've seen this happen, it's had fantastic results, immediate results in lowering the whole overall risk threshold. How can migrants become part of national health insurance systems? In a well-functioning national health system, it's tied to social insurance, which again often means tax. For nationals, as well as other people, it's all relevant. And how can we integrate into those tax systems, social insurance systems? What steps do we need to take? What proof is required? What costs are involved? When you run for your life, you don't stop to think, now have I got this document, do I have that document? We've seen it time and again. You have no sense of identity. Oh, I'm Gary Jones. No, you're not. Prove it. Oh, I don't have a single thing on me to prove I am who I am. Well, then you're lying, aren't you? This happens time and again. Actually, MasterCard, as in MasterCard, carried out some cutting-edge research a few years ago where they said that the greatest impediment for getting people into the workforce for social insurance was a lack of identity. Now, I'm sure they did that for all the right reasons. Possibly there may be a bit so they can then get MasterCards. I don't know. But the point of the matter is, it was a very interesting piece of research which showed that when the migrant joins the workforce, economies explode. It's fantastic. They're vibrant. All things start to happen. How, again, and I repeat myself, how do we make this happen? And it starts with identity. Coming up, there are some fantastic initiatives out there. I'm not saying that the train hasn't left the station. It has. But we need to then do a lot more in actually making sure that people have a sense of who they are and can tell other people who they are. That could be somebody from one of the key populations, for example. But we need to find ways where we can re-establish our identity for work and for our own sense of personal wealth. So, there is much to debate, and this is my last point. There is much evidence. But the more we know, the more we realize we don't know. This is one of the researchers' things, that when you open up that box and start to dig deep, you realize you've got to go down and down and down to actually find the situation. And it's a dynamic situation when it comes to migrants. It keeps changing. So we could carry out the most fantastic piece of research today, and we can actually nail it. What do we need? What do we got to do? This time next year, absolutely irrelevant, out of date, and just doesn't work. So again, how do we keep constantly aware, vigilant of what is happening? Please tell us. Please tell us. I will tell UNAIDS. We need to come up with this. We need to know what to do. And you're in the driving seat. Thank you very much indeed. Thank you. I'm now going to introduce our next speaker. Okay, and this is Dr. Christina Nostlinger. She's also a good friend of mine. Right, now, Christina is a health psychologist and behavioral senior scientist in Sexual and Reproductive Health Research Group, the Department of Public Health at the Institute of Tropical Medicine, based here in Antwerp, here being Belgium. Her expertise is systematic intervention development and community-based participatory research. She is also coordinator of the HIV SAM project, the Flemish HIV prevention and sexual health promotion program for migrants of sub-Saharan African origin. She has been involved in several EU public health programs and recently also conducted a rapid assessment on the impact of COVID-19 measures on migrant and ethnic minorities in Antwerp using a participatory research design. So, without further ado, I will happily hand over the microphone. Welcome. Thank you.
Okay. Thank you, Gary. Do we have a laptop here, actually? Can I have it? Or do you want me? So I would always have to say next slide, please. But then I would, okay. Okay, thank you very much. So I think, first of all, let me thank you for the opportunity to speak here and to present you and not so recent research anymore. As Gary mentioned, that this research was conducted in 2020. So actually we had our community workshop to discuss the results of this research really in Brussels the day when the lockdown started. And this has also driven many of us, I think, a bit into different directions and out of touch. So I'm really very happy to be here today and to see so many of you face to face. And I hope we can take up the work, as Gary said, update this, validate it, and also discuss about what does it mean in practice, which kind of practical recommendations can we draw based on this research. So why was it important in 2020 still to come up with this research? As Gary said, there's a lot of evidence. We have good epidemiological monitoring data in Europe. And just from this data, we already see, as you can see here on the map, that HIV affects migrants very disproportionately across European countries. So the darker the green you see here on the slide, the higher the proportion of people with, who are non-nationals in the respective countries among the new HIV cases. But that already shows us somehow how kind of rough our data is, because when we speak about nationals and non-nationals, or nationals and people born abroad, that's really a very broad category, and it can hide all kinds of different identities, as Gary already said. So migration patterns have changed, and they will continue to change. For instance, climate change in other parts of the world will also continue to change migration patterns. And so we see an increasing diversity also in the HIV epidemiology. So we really deal with very heterogeneous populations. And when we go down to it and really want to understand the situation of people with a migration background in precarious situations, then we don't have a very good insight into the dynamics. But if we are to develop effective responses, tailored, then we really need to have these insights. But I also want to make, to kind of say very clearly, migration as such is not a risk factor for HIV, but it is rather, as Gary also said, it's a social determinant of health that also interacts with other social health determinants that increase vulnerability to HIV, and this is really what we want to look at. And we have actually chosen the term precariousness rather than vulnerability, because sometimes vulnerability can be very vague, and somehow we may also contribute to vulnerabilizing people in such situations. So we choose for precariousness because it's much more tied to socioeconomic situations that people are living in, but also to the volatile status during the migration trajectory. People can lose their documents. They may have document one day, but then they may lose it the other day because of asylum decisions. Clearly, the most precarious people are maybe those who are living with an undocumented status, and we just have put up here one of the recent estimations, so it's really kind of big group of people that we're talking about in Europe, estimated to be between 3.9 and 4.8 million people. Of course, it's also hard to really estimate that, but that's one of the very reasonable estimations. So next slide, please. So in order to synthesize the available research evidence, what we did is we did a literature review, a systematic search and review, and we tried to summarize the evidence from 2014 to be able to capture the kind of migration peak in 2015 up to the end of 2020. And we looked at peer-reviewed, published research articles, and also tried to fill the existing gaps in a kind of a purposive way with grey literature. And in order to summarize the evidence, we developed three kind of research questions. So the first was to really understand the burden of HIV on migrant populations in precarious situations, and also to understand which of these groups are most affected by HIV. We also wanted to understand, like, what is their access to services along the HIV continuum of care, which, as you all know, HIV testing, access to treatment, and being effectively treated. But we also expanded this in a way to also kind of look at primary prevention, so actually before people are diagnosed, and also quality of life and well-being indicators as a kind of a cross-cutting indicator across the continuum of care. And finally, of course, if we want to do something about improving the situation, then it's also important to know what are barriers and facilitators that shape access to services. So that was then the third review question. So next slide, please. So I really tried to be very short. I don't go into the details of the methodology. If you have any questions, you are welcome to approach me or to ask it afterwards. This research has also been published. I don't know if it's now available to you or if it will be distributed, but okay. So the details are all in the paper. Okay, next slide. So altogether we found 133 articles. And so here you see how we kind of selected those articles. Next slide, please. So it's really quite a big amount of data. So it's not that there's no evidence available, but you will see in a moment that there are still quite huge research gaps as well. So the first research question was, what is the burden of HIV? And so we looked at different indicators. A proportion of new HIV cases, HIV prevalence studies. So if you have like a given population, what is the proportion of people living with HIV in that specific segment of the population? And also very important, post-migration HIV acquisition. So why is that so important? Because of course, maybe for a long time we had this picture in our mind that many migrants are actually coming, being HIV affected knowingly or unknowingly, would be coming to Europe. But now we really have the evidence that actually there is a large proportion of migrants who acquire HIV after their migration, after they settle in European countries. And this of course has very different implications for prevention. Here we really then talk about effective primary prevention that we need to invest more in. So in terms of new HIV diagnosis, there are many countries in Europe where actually more than 50% of the new cases were reported among non-nationals. HIV prevalence in different populations, you can find very high rates of HIV prevalence. We found studies between 3% up to 22% when it's carried out, for instance, among sex worker populations with migration background. And post-migration HIV acquisition, there is a kind of a uniform estimation, both based on modeling studies, but also based on clinical algorithms, that about 40% of migrants may have acquired HIV after they arrived in the European destination country. However, when we look, for instance, among people with injecting drug use with migration background, so this very, very high prevalence figure you see here, more than 90%, is from a Greek study among people who inject drugs with migration background. So indeed, we can say we have the evidence that HIV burden among migrants in precarious circumstances is higher than among the general population. And groups with the highest HIV burden here, we see these overlapping vulnerability factors. For instance, migrant men having sex with men or transgender persons, migrant sex workers, people of sub-Saharan African origin. In prevalence studies, we see that there is a high community prevalence as well. And then also migrants with irregular status, as they don't have access to services, so, which clearly is a risk factor. Now, in terms of the second research question, access to the HIV continuum of care, also here studies speak a clear language that migrants have reduced access to the HIV continuum of care, which also results in poorer viral suppression rates, mainly due to their late entry in care. And substantial gaps are actually also have been observed in primary prevention services. For instance, when we think about biomedical prevention tools such as pre-exposure prophylaxis, in many European countries, this is actually only taken up by gay men from national origin in the countries they are living in. And when it comes to migrant populations, there is quite some inequality in terms of the access. It was also interesting to, when you look at the figure here, the blue bars, that's about 5 countries that are actually able to document the full HIV continuum of care for their migrant populations. So you see, they don't reach the 90-90-90, but 5 countries is also really, we cannot really tell a lot. Huh? So we really also need to do a better job in documenting those things. And the weakest step in the HIV continuum of care that was identified is actually access to HIV testing. Many opportunities were identified as being missed in the general health services, also in primary care, although we do have very good evidence that community-based outreach HIV testing services is a very effective means to reach those populations, and also cost-effective. But it has not been studied to the degree necessary to actually show really its effectiveness. Okay, next slide, please. And then when we said expanded HIV continuum of care, so it's also very important to look at the quality of life and the well-being of people living with HIV, and also how these indicators may cut across all stages. And we really saw in the evidence that the practical and support needs of migrants are really underserved. So there is insufficient provision in terms of the practical and psychosocial needs. Gary also talked very impressively about that when it comes to housing, to employment opportunities. So there are really stark policy barriers that also make it impossible for people to integrate there. And we see substantial gaps in the support for coping with the multiple migration-related stresses and also with the mental health needs. And there are very few studies on self-reported quality of life outcomes. It is almost as if this is something that is not of any interest, really. So, and then again, especially in the grey literature, there are examples of community-based holistic services and how they actually can integrate all these several aspects that are so important when people have to cope with the migration-related stresses. Okay, next slide. So this is now about the third research question. Remember, this was about determinants that shape access to the HIV continuum of care. And we tried to kind of categorize them on different levels, on the policy level, on the healthcare level, on the community level, and then also how does this play out at the individual level. Gary also mentioned that in his introductory notes. But really the major thing, and the one that could be changed, though not so easily because the political climate is not such, are the laws and regulations that restrict access to health care. And not only to HIV, but to universal health care in general. But when we look how does this play out at the level of HIV medication, for instance, for undocumented migrants, so we see that only 15 countries in the EU provide access to antiretrovirals free of charge, and in other countries it's highly restricted. For instance, access to health care is only granted in emergency cases, emergency care, but HIV, as now being qualified as a chronic disease, would not fall under that. Or in other countries like Belgium, for instance, access is granted through a very complex social welfare system where people are highly dependent of migration services and of social welfare services, which are like two silos, two different worlds that do not very easily collaborate and work together to the benefit of the client. So that is really something that is the major policy barrier, but there are other barriers as well. So that would be the next slide. So trying to bring all those barriers together, I mean, I could, go on forever, but roughly we can bring it together in a kind of a narrative in which we say that the socioeconomic and the legal insecurity, they create situations of risk in which people, in order to survive or in order to cope with those situations, expose themselves to risk. So there is increased risk of gender-based violence, of transactional sex, of sex work in a not regulated way. In addition, on the level of the healthcare system, there may be language barriers, there may be healthcare providers not knowledgeable themselves how to navigate this complex system for their clients. And at the community level, there is also HIV-related stigma. This all leads to fear, especially among undocumented migrants, fear to get in touch with the system. So there is also at the individual level, kind of avoidant behavior, also resulting in low prevention demand. And taking all this together, it leads to reduced agency on the level of individual people, which increases the HIV burden and worsens HIV outcomes, especially if there is already a high community HIV prevalence. So in a nutshell, trying to condense all those factors. Okay, next slide. So we have also worked around recommendations, and what we have tried to kind of, discuss what does this mean and how could it be translated into concrete policy recommendations. So first things first, removing the policy barriers is really key in improving access. And integration of especially the people with the, let's say, highest precariousness, people of undocumented status, really to integrate them in the healthcare system and realize the right to universal healthcare. But of course, it's clear that it's not so easy to realize that in a very xenophobic political environment. So inclusiveness would maybe also be a way forward to really grant PrEP, PEP, low threshold HIV testing for everyone and also free HIV treatment really for everyone. Next slide. This is my last one. Very important, strengthening community-led initiatives because they have been shown to, as best practices, really to be able to solve many of these issues at the community level, especially also stigma reduction. So stigma which really cuts across all the stages of the HIV continuum of care. And finally, the question for us, we live in Europe, we want to be a united Europe. So equity and non-discrimination is really at the forefront of all the European policy documents. But we also know that the implementation at the national level really lags behind. So our question would be, what is the role of the European Union in really taking leadership and promoting those human rights-based policies? And as it was already said also this morning in the introduction, how the crisis with Ukraine refugees was handled may serve as a good example, but we also risk to create like two different speeds in terms of how we deal with this problem, and that should not happen. Thank you very much. So I don't know if we now have like time for questions or discussion.
Yes, got a few minutes for
Yeah,
questions.
okay. Yes, please. Yeah, maybe I didn't mention that, but I should maybe also say special thanks to, you know, all the people who participated in this research, and especially UNAIDS also for taking the leadership and the financing of this research. So sorry for that I forgot it. Okay, but now your question, please.
Morning, thank you for your presentation. I'm Luciano Nigro from Italy. Sicily. Okay. I think that the situation of the south of the Mediterranean area is not there, because I'm not saying that we have more migrants than other countries, but we have a peculiar situation, because we are full of these new migrants, young people, minor, without parents that they are there, and because of the new law, I'm not okay. Just I do the photograph of the situation. Lots of these people, they are on the street. They don't have any welcoming facility. This means that if for us, Italy, south of Italy, the rate of unemployment is 33–40%. For these people is 100%. So they are immediately involved by the criminal organization. So they are involved in the drug market, sex market, and as it happens in the past, when you start to be a pusher, you become a user and an abuser, and they live on the street. So the barrier for these people are very, very high to reach and even to leave this market, because the main problem for everybody is the document. They, up to when they don't have the document, they are not able to hear you, even for associations that are welcoming, confident, because they want to move, they don't want to stay there. Their plan was another one, but they are there, and there are people that are there up to 7–8 years waiting for the document. So the main and important advocacy and things that need to be solved at the European level, probably, is to facilitate the situation of the document. Without the document, you can't live, and you can't leave the market, the organization. And this is very, very normal now in our area.
Yeah, thank you very much for your contribution. I mean, I really had to be short for this summary, but I remember that we also had included certain couple of studies that were done, for instance, in asylum centers, showing that, for instance, when it comes to HIV burden, there is not so much difference with the general population. So again, back to that, infectious diseases come later. Again, back to that point of post-migration HIV acquisition.
And just the last I forgot. In Italy, the health law is very good, because we give everything for free. But there is no information, and there is also the lacking of a low threshold health service. So this is but when we find a positive, the treatment is there. The problem is to test them, to support them, and the prevention. Yeah. Even if the law is there, we don't have services.
Hi, Harvey from Black Beetle Health. So I just wanted to refer to one of your slides where you talked about relations between sort of MSM and transgender persons, and I'm wondering if that was intentional terminology or if that was something that we could discuss in a bit more depth, just to differentiate between identity and maybe practice, because we know that that feeds stigma. So talking about maybe MSM as a whole, as being at risk of something, as opposed to specifically maybe GB-MSM, so maybe gay and bisexual and other men and sex with men. And also, when we say transgender persons, you know, is there any data to support whether or not that's transmasculine or transfemme? How deep can that data go, and what does it tell us?
It cannot go that deep, really. Yeah? So we don't have really very specific studies, at least not. Maybe there are newer studies after 2020, but here we did not really have included studies that really tell us about, let's say, transgender people and their HIV risk.
So you talked about the connection between relationships. So I'm just you talked about the relationship between the, you know, on that line. So I'm just wondering if that was, and in the most respectful way, was that an oversight of how that was collected, or was it there was very few numbers in the studies that you saw in the systematic review of the literature? So I'm just wondering which one it was, as a non-criticism, as a curiosity.
Yeah, I know. No, I think in relation to sex work, for instance, we do have some evidence that there is an increased risk involved.
So do we know if it was, so what was that evidence, and do we know if it was towards sort of one group or another group? It's okay if we don't know, and we can probably discuss a bit.
Yeah, I would say transgender women engaged in sex work.
So that's more specific than transgender persons, you see what I'm saying? Yeah, so that's my question.
Okay.
Good morning, and thank you for your presentation. Just to buttress what Luciano said, actually I should say that I'm Jacqueline from Kenya via London. And in terms of policy, I think it was interesting to hear about the Italian situation. But I wonder whether in terms of policy we need to look at rule of law, because what compounds the situation in places such as Italy is law enforcement. So you might wait for 6 or 7 years to get your documentation, but actually you're under the control of criminal gangs. So alongside the policy enforcement, there has to be law enforcement, because you may have your documentation, but you still do not actually have your freedom. So I think that's just a matter for us to consider in terms of looking at a holistic approach, looking at really the context of the issue.
Good morning. Mohammed from Netherlands, Stichting Africa. My submission was about the sex workers and the new immigrants that joins the bad group. I wish we can have the way we apply to the European policy among the immigrants, because look, I've been doing research about some immigrants in the US, but they obtain a work permit in their process of asylum. So they can access the work market and they don't enter the dangerous organizations, the illegal labor market, like and drugs and stuff. So, but what I was seeing in the Netherlands, because where I come from, the immigrants are entitled to only 6 months per year. And you're not on the guarantee the next 6 months per year, yeah, and you're not on the guarantee for the next year that you obtain a work permit. And there's a very tough measure to prove for you to obtain a work permit, because I followed one for some guy. But you have to prove in the whole EU that he can do that task, so that you fail to find another worker in the EU that can do that task. So it's quite of a big challenge in the working society to merge the immigrants into the working society. So I'm asking, so we try to find out the policy that can include the immigrants to obtain work permits, not limitedly for like 6 months, like where I come from. I don't know what's for other countries, like for a bit long time. Maybe if somebody is stable for 2 years, he can plan something. But 6 months, then you go back to the risk where you were coming from. So I think that one should be forwarded also, please.
Yeah, thank you very much. I think it would be very good, like if in the afternoon when we will have time to really think about recommendations, to maybe concretely formulate such things, because now we approach it really from a health perspective, but like many of your statements now, they really relate to migration policies, and so far these have been like two separate silos really, but they have to influence each other somehow, because like you say, the employment situation really affects health as well. So it would be good if we can make this more concrete, I think.
Good morning to everyone. Good morning to everyone. My name is Ian. I'm from Greece. Just to complement to what everyone said, what we have seen in Greece after your study from 2020 to 2022, there is a huge rise in risk behaviors in almost all the vulnerable communities inside Athens specifically, because when you take into consideration during the lockdown, you are fined if you went out of your house without an excuse. So most people who are in the vulnerable situations, who are restricted by all of these policies that we mentioned here, could not access even the labor market or to do the black market jobs that they usually do. Mm-hmm. We are talking also about the sex workers also. It was difficult for them to actually work. So this put them in more risk and put them in more danger and even more risk to become drug users, as we mentioned, to be exploited even more. And I just wanted to mention this because it's important to also take that into consideration. It was 2 years. It was, for some, it was a short period. For some, it was a very huge period of time because it was restrictive for every one of us in this room, who we have the freedom of movement. But for some who don't have that freedom of movement, it was even more restrictive. And it put them in a very precarious condition where they had to survive and to make a living and to pay. So, for example, in Greece, you receive 150 euros per month as an asylum seeker. If you're not an asylum seeker, or even if you're an asylum seeker, what can you do and how can you survive with 150 euros per month for 2 years? So you have to take all of this into consideration and to take this as a risk and how it increases the risky behaviors for all the people in the migrant communities.
Yeah, I think you're right. And I think data is also coming out now really showing that during COVID, those socioeconomic factors increased not only vulnerability, but it can really be shown in terms of morbidity and mortality also among migrant populations. Okay.
Thank you, Christiana. Hi, my name is Ben. I'm from the UK. I'm thinking of the comments from the gentleman from Sicily and Greece. Was there any reflection on the level of precariousness in the host countries? I mean, I think our friend from Sicily is talking about a north-south divide, that very precarious countries are being impacted by migration in different ways than countries with thriving and growing economies, for example, and the level of unemployment.
Yeah, thank you for the question. Well, I didn't show this because I had to be short, but it's really, the evidence we have really reflects more, let's say, the research infrastructure that exists in Europe. And so there are a few European countries like the UK, Spain, France, that actually account for the bulk part of this research. So there are many countries where we really have blank spots in this.
Sorry, yeah, I'm online. Sorry, folks. It's just simply to say is that we're running about 40 minutes behind schedule, and that's okay because it's been a fantastically rich debate. But what we were thinking, if we could just, if it's okay with you,
For sure, yeah.
Christiane, if we could take our break now, carry on the discussions, we can do that outside there, and then just see and bring these points out during our interactive group sessions, which of course is next on the agenda. But thank you very much indeed. Thank you, Christiane. Thank you.
Just send me.
When did you receive the one you...
From Chelsea. This one was on the table. The Chelsea will send me this one. And you see the break is not the same time. 11.
Okay. Can I give you my email and you send this one to me?
Chelsea, c'est pas les mêmes. Hein? Regarde, this one and this one. Tu peux lui envoyer s'il te plaît?
Which one is the red one? I believe it's... This one is the same as that one, is it not? Yeah. Then this is the final one, yeah.
C'est pas les mêmes? Non, c'est pas les mêmes. Regarde, break 11. Et ici, c'est 10h45.
Okay, and this one is the last one. It's the last one, but we're already running late. But
Okay,
this is the last one.
Ok, bon, on va mettre ça.
Celui-là était sur Twitter. That's the one I found on Twitter. No, I think they amended it a bit, yeah.
Donc, on peut mettre juste la bannière alors? Non, mais oui, mais c'est pas... Tu veux OK? Tu m'as envoyé, c'est pas? She sent me one. No, no, it's okay. No, you can send me. Yes. You know, on the group, there is better, because this one.
Hello. So we're starting the next session. We're running behind, so we need to get everyone settled back in so that we can begin. So I hope you've had a good comfort break and had your coffees and teas. So we're starting the next session, which is going to focus on experiences of the community we work with across Europe. So we are going to have 4 different organizations giving a bit of their perspectives in different countries. We are part of a partnership called Mi-Health HIV Partnership. So it's a partnership which is funded by Gilead's Zero Inning program. And we are working in 10 countries, including the UK. So today and that means we're working in the Netherlands, Sweden, Cyprus, Greece, Germany, France, Sweden. Which country have I forgotten? UK and Portugal. Yeah, and so today we are going to have case studies from Belgium. So Eswa is going to be giving some case studies with sex workers. We are going to have a case study from Greece, working with migrants in the frontline. We will have a case study from Portugal, mainly focused on Latin American migrant communities. And finally, we are going to have a case study from France. Kim is going to talk about the work they do with mainly trans women and sex workers there. So, is that correct? That's correct. So anyway, as you know, for a long time we've had, situations where we work in isolation as communities. Everyone gets on with their own work, but as we started listening across Europe, we recognized that the challenges that we experience are cross-cutting. I mean, they are similar, though in different environments, but we have the challenges all the same. And we are, traditionally AF has worked in the UK, so our experiences have been a bit better because the systems are much more better there, given the fact that people have unrestricted access to testing, treatment, prevention, testing, and treatment. And even though there are some challenges within the system, at least the experiences tend to be better. So we came together as a community groups working with migrants in the front line and created Mi-Health HIV Partnership to be able to work together. So we are doing over 3,000 tests across the 10 countries. We are developing resources for promoting awareness, including PrEP and U equals to U. You can see some of them at the back. Hello? Yep. And then we are doing what we call a community of practice, which is mainly learning exchanges, so being able to do things together, sharing case studies like the ones we are going to do today. And so first up is going to be Foundation Portuguese, which is a community organization fighting against AIDS. And Filomena, who is the president, is going to come and introduce the work they have been doing with migrants from Latin America.
So, good morning. Thank you very much for this opportunity, and especially I want to present Paula because she is also in the front line of this project, but also to thank Dennis to the Africa Foundation for this privilege to be on this project with all the other countries that are participants. Thank you very much for our foundation. Paula Costa is our educator advisor, and she's also advisor from the board, the administration board, and she is special giving by the education ministry to follow all these projects with us. So, Paula, and she's also a nice coach.
Thank you, Filomena. Thank you, everybody. It's a pleasure stay here with you. Thank you for this opportunity. And I want to share the work of this team and this part of a team. We are more people, but these are we are focused in this project with MI Care. So we are not only women, okay? There are guys. So. This is the goals of the project, and Mi-Health care tell us to focus with a point, and the point I share with you is the HIV testing initiatives, and I bring to you the first quarter of this project, okay? So we can find 330 migrants, and this is the goal, but we don't get it, this goal. So please, next slide. I share with you the strategies, because I think it's a good practice. We could bring to us a number, a very good number for a quarter of project. So we start in journals, okay? Some of these migrants are sex workers, and we start to find them in journals. And what we're gonna do next? We make a confall, and we start the relation with these people, okay? Then we meet, and this person over there is the case manager. Okay, the case manager is the person who start the relationships with migrants. Okay, this is the point of this project. So this is one kind of strategy, because they are the community in general, and for the community in general, we're screening with very opportunities we establish with the partners in the other organizations and other partners. So this data is a global data for this strategy and the community screening, okay? So in the first quarter, we get it reach 30% of the global goal. This picture, you could see 3 peoples. They are a nurse that's screening. They are a psychologist. They talk with these people. And we get it some data. And in the first quarter of this project, our data was different of the data of project. And this is one problem for us, because we have to adaptate our data to the project data. Okay, do you understand what I mean? Yeah. Huh? So this screening occur in house. This people is in her house, in her home. Okay? And this is the most innovation in this project. We go to her houses. And usually there no one person, but 3, 4, 5 persons. We're screening one of each other, okay? Because we guarantee the privacy. Okay, what we do in group maybe was pre counseling and post counseling. Okay, the rest is one-to-one. So you could see 4 tests, because we screening HIV, hepatitis, and syphilis. Okay? In Portugal, the government indicate the HIV and hepatitis was priority. B and C. Okay? The guideline for the Portuguese government was do B vaccination to all people, old people, but we don't start yet. So this is the point. This is the point. This strategy is it's a good strategy in our mind, because these people tell us, if you don't come here, we don't go to you. So this is a point we want to share with you. Next, please. Who are these migrants? Mostly are from Brazil. The other one over these countries. Why Brazil? Because language. Okay? Just because language. And because Portugal is a door of entrance in the Europe for Brazilian people. Next, please. And who are they? So 27 females, mostly from Brazil and other countries. Most of them